Today we will be discussing on a topic case of a 20-year-old female whose presenting complaints were facial puffiness since 2 weeks.
Okay. So, what? Okay.
So her history of presenting complaints were that she had facial puffiness, which was insidious in onset, and there was increase in symptoms since the last 3 days, and there was no associated decrease in urine output, frothing of urine, no history of itching, hoarseness, or any history of pedal edema or any abdominal distension.
So, what is the differentials at this time?
So the differentials would probably facial edema we can consider as if the edema starts from the face, then it would probably we should think on the line of renal disease. It can be nephrotic syndrome or any kind of AKI producing or any glomerulonephritis. We should check the BP associated with it. And also a patient presenting with edema usually present if he's having pedal edema, which increases towards the evening, and in having orthopnea, PND, or any cardiac symptoms would probably be cardiac in origin. If the patient has abdominal distension, then it decrease. Then the pedal edema, then the facial puffiness is there. Then it can be CLD. But usually, if it's facial puffiness, which starts, it would usually be a renal cause. That would be my first differential, sir.
So, you are given some details.
Yes, sir.
What do you think about these details?
Facial puffiness, which was insidious in onset.
No. You are given some negative history.
Oh,
so,
okay,
does
sir.
it rule out renal disease?
Yeah, there was no history of decreased renal
No
urine.
hematuria, no oliguria. So, what do you think? Do you have any other differential diagnosis?
It can be maybe a allergic history, or if it's just a periorbital puffiness, it can maybe be the bite site of a Chagas, this Trypanosoma cruzi producing this one sign is there, which may present only as facial edema or one unilateral periorbital edema.
Do you consider the possibilities of orbital cellulitis, cavernous sinus thrombosis, angina edema, edema of severe cough like whooping cough, infectious mononucleosis? Do you consider any such a differential diagnosis?
Yes, sir. I would consider the differential. Usually, orbital cellulitis would be unilateral. Cavernous sinus would usually present initially unilaterally, then would be bilateral, then then other whooping cough, it can be there. Then the other symptoms like maybe a superior vena cava SVC syndrome producing facial congestion, then later producing facial edema can be there, or
Consider
any
why differential diagnosis. Do you know any worm infestation, parasitic infection, which can produce puffiness face?
puffiness of face can be produced by certain parasitic infections.
Like
Then the
Trichinella spiralis.
yes, sir.
Now, carry on.
Then coming to the review of systems, the patient had a cough for 4 weeks, which was non-productive and having no diurnal variation, which increased on lying down and associated with chest discomfort. There was orthopnea as well as dysphagia. So when we review this cough, it's having a prolonged duration and which was non-productive, and there was no diurnal variation. It increased on lying down. Usually there are certain conditions which where the cough increases on lying down, which can be any postnasal drip causing chronic pharyngitis, then GERD, which produces this metallic taste also in the mouth, and which causes is a differential of chronic cough, and especially nocturnal cough can be cough predominant asthma, but here there is no diurnal variation. There is associated chest discomfort. So it also suggests this GRD, but there is orthopnea. Orthopnea is a very strong indicator for a probable cardiac disease. And there is dysphagia, which is also supportive of GERD. So my main differentials at this point would be GERD or any cardiac cause producing the same. Then coming to the past history, there are no known comorbidities, no history of allergy to any drugs or food, no history. There was history of consumption of blueberries the day prior to the facial puffiness started. Oh, okay. So certain blueberries maybe can and the patient may be allergic to the blueberries. It can be a differential. So the
So
provision.
this is your differential diagnosis. Am I right?
Yes, sir. So coming to the general examination, the patient was moderately built and nourished. There was no pallor, no icterus, no cyanosis, no clubbing, no lymphadenopathy. Facial puffiness was present with swelling present till the lower neck, and the vitals were she had tachycardia of 130 beats per minute, BP was stable 140/80, respiratory rate was 17 normal, saturation at was 98% at room air. So, so as we had discussed earlier, the main differentials would now be an angioneurotic edema bar anaphylaxis, and she was having edema of upper extremity up till the lower neck.
Do you make out anything now?
Hello, sir.
Can you make out anything now?
There is a probable thickened nerve. Usually nerves are palpable. Can it be any thrombophlebitis or anything? Is it tender to touch?
Yeah.
Hello?
So you have this vein here, you have another vein here, tortuous vein here, you have
So there
veins
is
here.
a chance of there is a chance of venous congestion. So venous congestion producing okay, venous congestion which can be a suggestive of a SVC syndrome or any obstruction of the veins lower down the drainage pathway. The supraclavicular area seems a bit, not supraclavicular, lower neck also seems a bit enlarged. There is swelling there. Coming to the systemic examination, there was bilateral V's which was present, CVS,
Now what's
GH.
your differential diagnosis?
Bilateral V's which was present, so it can be allergic reaction, sir.
How does allergic reaction produce very prominent veins in the neck?
Maybe any allergic reaction. Oh, maybe. I'm not sure, sir.
So this patient has got bilateral V's. He has got dyspnea while lying down and deglutition, dysphagia also. So something may be in the mediastinum. Okay.
Yes, sir.
So what is your plan of investigations? These are investigations done.
So,
It does not give any clue to any diagnosis. Liver function is normal, blood counts are normal. Okay.
oh, okay. She's having coming to the chest X-ray. She should I go in a systematic way or
Just tell your impression.
my impression would be a right hilar lymphadenopathy. Then
This
the
this this
mediastinal
track,
widening is there.
this shadow starts from here, goes like this, goes like this, and goes like this, and goes like this.
Yes, sir.
So what do you think it is?
So it can be a thymic mass or uh,
So we
any
went. So what is the differential diagnosis of a swelling in that area? You said alarm node. It can be,
retrosternal goiter also can be there.
so it can be retrosternal goiter. Yes. What are the investigations you plan? If it's a retrosternal tumor, what possibility you consider mind?
Retrosternal. So we can consider it as a differential of retrosternal goiter or thymic mass or any. We should also get a lateral view of the lateral X-ray and differentiate at which mediastinum the patient has the mass and whether it's in
So,
the anterior.
so if it is the posterior mediastinal mass, what's the differential diagnosis?
Posterior mediastinal neurogenic.
Neurofibroma or esophageal related. If it's anterior mediastinal, what's the differential diagnosis?
Anterior mediastinal can be thymic mass.
Thymic mass, yes. Anything else?
Then it can be uh,
Retrosternal goiter. It can be
retrosternal goiter.
a germinal cell tumor
Uh,
or it can be lymphoma.
okay, okay, sir.
So, what investigations you do next?
So I would proceed with the high resolution CT of the thorax and
Okay. Any other blood investigation you want to do in relation to the differential diagnosis you are given?
I would also check the thyroid function test.
Thyroid
Then
function test is come as normal,
yes,
slightly elevated TSH. The normal T24. What do you call the situation?
normal T34, higher TSH is subclinical hypothyroidism, sir.
So, do you treat such situations?
Usually, subclinical hypothyroidism, if the patient is subclinical hypothyroidism is a biochemical diagnosis. If the
Do
patient
you
is
treat or
having,
not?
I will treat if the patient is either pregnant or having symptoms.
So, usually it's a debatable topic whether to treat subclinical hypothyroidism or not. The patient's got gross edema. The patient is markedly obese. If there's an infertility is there, there are few situations where you have to treat. Otherwise, is there a benefit of treating or not is not known. If there's severe dyslipidemia, again, you may treat. If it's a coronary heart disease, you must treat. So there are very few situations where you treat subclinical. So ignore that part. From the top to bottom, can you read what are things done and why it is done?
Alpha fetoprotein was 0 to 8 is normal and
Why
1.
these two investigations?
AFP usually would be is a tumor marker, so
For
it can
what?
be
For what? Which
for
tumor?
AFP can be present in this HCC and which can be metastasis to the lung
So we are thinking about germinal cell tumor
germinal
in
cell.
the mediastinum. That's why these two investigations are done.
Oh,
And why LDH? Why do you do
LPH.
LDH?
The normal range is 140 to 280.
Yes,
The usually any kind of malignancy produces
that's
a
right.
high LDH.
So your clue here, there can be some malignancy somewhere there. Calcium,
Calcium 8.6, any thymic
okay.
mass associated uh, can produce the same or
Can,
retro.
can malignancies produce hypercalcemia
Yes, sir. As a paraneoplastic syndrome.
and a Panama's syndrome? Okay. What happens to calcium in tumor lysis state?
In tumor lysis, it would be decreased, sir.
So you wanted a CT and CT shows what?
The CT impression is a poorly defined heterogeneously enhancing soft tissue density lesion in the anterior mediastinum, predominantly on the right side, encasing the mediastinal vessels with extent and relations as described. The differentials can be a thymic carcinoma, lymphoma, a germ cell tumor, and suggested HPR correlation. Few enlarged supraclavicular mediastinal lymph nodes was there, so which can be possible metastasis and minimal pericardial effusion, mild right pleural effusion, and segmental atelectatic bands in the right upper lobe.
So what do you do next?
So at this point, I would cons- I would consider a tissue biopsy, sir.
So this is the CT. Can you see?
Yes, sir.
The vessels cannot be seen. This compressed vessel such a way that the vessels cannot be seen separately. So,
Yes.
as you suggested, a biopsy was done. It shows
Malignant round cell neoplasm, sir.
what do you do next.
Uh, so I would proceed with the immunohistochemistry.
So we are waiting for that result. So what's your final diagnosis now?
So my final diagnosis would be a anterior mediastinal mass producing HPR diagnosis being malignant round cell neoplasm producing superior vena cava syndrome compression and obstruction causing this facial puffiness.
So superior vena cava syndrome, anterior mass, round cell, neoplasia as the basic etiology. So tell me, what are the symptoms or presentation of superior vena cava syndrome?
Usually, the patient would be having facial congestion, plethora, and then having like like when we are upright for quite a long time, and the eyes would be congested. There may be subconjunctival hemorrhage. Then on clinical signs would probably be raised JVP with which is not pulsatile, and there would be dilated veins if the patient is having an obstruction below the site of joining of the asparagus vein. Then the patient would be having it is having better prognosis because the blood can come back into the superior vena cava through the asparagus vein. But if it is the block is below the asparagus vein, even if the patient is having a collateral through the asparagus, the blood can drain back into the right atria.
So how you clinically differentiate these pre-azygos or post-azygos?
Pre-asparagus would usually be having anterior thoracic. There would be dilated veins in front of the chest as well as in the abdomen, and
Yes, okay.
but yes, post-asparagus it won't
Okay.
be there.
So the question was, what is the commonest symptom of superior vena cava obstruction?
Symptom would be uh, face, facial congestion,
Okay. The
conjunctival congestion.
commonest symptom of superior vena cava obstruction is headache. Why do they get headache?
Oh, yes, sir.
Why do they get headache?
Because of due to the venous engorgement, sir.
So where does superior vena cava arise from? How is it formed?
Due after the joining of the two uh, brachiocephalic trunk.
Okay. So brachiocephalic veins are formed by what?
Inno, uh, inno,
Innominate vein, and how is
uh,
innominate vein formed?
innominate veins by the internal jugular joining of the
So
internal jugular.
how is internal jugular vein formed?
Internal jugular vein is formed by the joining of the posterior facial and
Internal jugular vein is the continuation of sigmoid sinus.
sigmoid sinus. Yes.
So so it is the blockage of superior vena cava which produces back pressure on the brain. And cerebral edema is the cause for headache.
Yes,
So
sir.
tell me some other causes for superior vena cava syndrome.
Superior vena cava syndrome usually will be caused by a non-Hodgkin's lymphoma, and while Hodgkin's lymphoma producing this is quite rare, and it can also be due to either a thrombosis or a mechanical compression. Then it can be produced by any kind of mass which is infiltrating there, or any kind of malignancy producing a prothrombotic state in the body.
Superior vena cava syndrome is bronchial carcinoma. Then superior vena cava thrombosis. What are the causes?
Superior vena cava thrombosis can be due to any kind of any cannula central line which we have inserted then through the internal jugular vein.
Okay, that's fine. So this is a case of superior vena cava syndrome. And why does blueberry comes here? Because the
Blueberry.
patient was misleading the doctor and the casualty, saying that everything started after taking blueberry.
Okay. Blueberry, certain lymphomas can exacerbate while if the patient is having any lymphoma, a Hodgkin's lymphoma, especially if he drinks alcohol, then he'll get lymphadenitis. Like any relation with that, sir?
Alcohol produces pain, not lymphadenopathy.
Pain.
Okay,
Yeah.
so this is the lateral view of the mediastinum view which you are suggesting to localize the tumors, anterior, posterior, and middle mediastinum. So it's a very interesting case of superior vena cava obstruction with the round cell neoplasia, presenting the casualty with puffiness face, saying that I am having this swelling of the face ever since I consumed blueberries and misled the doctor. Thank you.
Okay, sir. Thank you, sir. Thank you for the opportunity, sir.